Good afternoon, everyone, and welcome to today's webinar, North Carolina Medicaid's Move to Managed Care, What Healthcare Advocates Need to Know. Presented by the North Carolina Justice Center, Disability Rights North Carolina, the National Health Law Program, and the Charlotte Center for Legal Advocacy. I'm Brendan Riley with the North Carolina Justice Center, and I'll be moderating today's webinar. Joining me today as presenters on this webinar are Elizabeth Edwards, Senior Attorney with the National Health Law Program, Misha Evans, Policy Analyst with Disability Rights North Carolina, and Doug C., Senior Attorney with the Charlotte Center for Legal Advocacy. Before we discuss today's agenda, let's cover a few housekeeping and logistical items. We are using GoToWebinar for today's presentation. You can either use your computer speakers or your telephone to connect to the audio portion of today's webcast. All audience members are in listen-only mode. Many of you submitted questions ahead of time when you registered, and we try to incorporate relevant information from your questions into today's presentation. While you are muted, you can submit questions throughout the webinar, and we encourage you to do so. You have to use the GoToWebinar questions pane, which should be on the right-hand side of your screen. Please feel free to submit questions at any time, but we will only be answering your questions during the Q&A period at the end of the webinar presentation. So we've reserved the first hour of this presentation to go through all of our slides, and we say the last half an hour or so to make sure we get to your questions. So feel free to send them throughout, but you can also ask questions at the end when we open things up for questions. Also at the end, we'll have a short evaluation survey that we'll ask you to fill out once things wrap up. It'll only take you about 2 minutes, but you can use that to share your feedback with us, to let us know what you liked about today's webinar, what other topics you might want to get more information on in the future, and generally give us feedback. So please do that when you wrap things up. After the webinar, we will make all webinar materials available, including the slides, a recording of the webinar, and transcription. And some of these materials are available today as handouts, which you can download in your GoToWebinar pane. You should find them right below the questions pane on your right-hand column for GoToWebinar. The handouts you should have there will include a copy of the slides, 2 fact sheets from North Carolina Medicaid, which include an overview of Medicaid managed care, as well as a fact sheet on the enrollment timelines. And there's also a new public and beneficiary-facing fact sheet for many of our organizations, as well as NC Child, Legal Aid of North Carolina, and Pisgah Legal Services. And that fact sheet focuses on the changes coming to Medicaid. You can download and save these materials, these handouts, at any time during the webinar. Also, closed captions are available for today's webinar. The link on your screen here is also available in the chat box in your GoToWebinar pane. It should be the first message you saw pop up as soon as you join the webinar. This link will open a separate page in a new window, which you can resize and move so that you can watch both the captions and the webinar simultaneously. So today we have a large and diverse group of people on today's webinar, which we're very excited about. This group includes many healthcare providers. Today's webinar is going to provide an overview and also a deeper dive of some of the most pertinent issues for Medicaid beneficiaries and their advocates. We're going to touch on a number of issues that are particularly relevant for providers, but we're not going to go into depth on a few, such as provider payments, contracts, care management, and other issues. For more information on those issues, we will refer you to a series of trainings conducted and recorded by the state. We'll have a slide on a few of these topics that we'll go over briefly, but we are going to focus on topics that are particularly relevant for beneficiaries and their advocates. All right, so let's do a quick review of the agenda. Today, our presenters are going to discuss the following issues. We're going to do a quick background on North Carolina's Medicaid transformation. Then we're going to dive into enrollment timelines, the expected issues, who's eligible, who's in, and who's out. We'll also cover changes to services coverage, as well as administration. We're going to go deep into beneficiary rights and protections, some of the anticipated issues and problems that we'll need to watch out for, and also discuss how you can get help for beneficiaries. After that, like I said earlier, we'll take your questions and do answers for about 20 to 30 minutes at the end of the webinar. All right, so we've got a lot of material to cover, and we want to make sure that we have plenty of time to answer your questions. So I'm going to go ahead and get things started, and I'm going to turn it over to Elizabeth Edwards of the National Health Law Program. Elizabeth, your line is now open.
Thank you, Brendan. And just for everybody's information, some of the slides that we have we'll go through fairly quickly, but we are trying to make sure we have plenty of time reserved for the end. So if I go through this fairly fast, just know that we'll have time for questions at the end. So quickly, we're going to go over the background of why we're changing to managed care, what exactly is happening, and the general timeline. So in general, Medicaid as it exists now is a fee-for-service program. So it simply is an entitlement program that provides health insurance to many low-income populations. And we're talking about more than 2 million people in North Carolina, with additional over 100,000 children covered by North Carolina Health Choice, or CHIP. And like I said, currently Medicaid operates as a fee-for-service system where the state simply pays the providers when they provide the service. And currently we have Community Care of North Carolina, CCNC, helping to coordinate the care for physical health care services. And we have the local management entities, LME, MCOs, managing behavioral health care. So it's not that we don't have managed care in North Carolina, but we are moving towards more comprehensive managed care. So like I said, we do have some existing managed care in North Carolina through the LME MCOs. They only really manage care for mental health, developmental disabilities, and substance use disorder services. That includes the innovation waiver as well as the B3 services. And managed care in this system for the LME simply means that they receive capitated payments and operate a closed network of providers. Capitated payment is simply that they receive a per member per month payment. Currently, we have 7 LME MCOs operating within the state, and they will continue to operate for the next few years, and we'll explain more about that later. So transformation. We've been hearing about this for a while now. It started in 2015 with the General Assembly directing DHHS to change North Carolina's current fee-for-service Medicaid structure to a managed care one. And so that is taking the LME MCOs and adding more managed care to the program. This only changes how Medicaid is delivered. It does not at all change who is eligible for the program. Some of you may remember when DHS submitted the 1115 waiver to CMS in 2016, there was some mention of an expanded Medicaid population that is not actually part of the transformation program. So in 2016, the waiver was submitted and it was amended in 2017 after a sort of listening session round by DHHS, and it was approved in November 2018. And since then, we have sent out RFPs and awarded contracts for the plans, the commercial plans for managed care, and phased rollout is set to begin in July of 2019. So what are we talking about with Medicaid transformation? The bill from the legislature directed the state to move towards an integrated care model, which is supposed to be where a person's physical health care and behavioral health care is treated sort of as the whole person and addressing both medical and non-medical drivers of health. So part of the North Carolina system is to include what we're calling healthy opportunity pilots to address social determinants of health. And other features of the program include ombudsman program for beneficiaries, some provider support that is a bit more than typical managed care, and some other features. Generally under Medicaid managed care, there are different provider networks by plan. So in our state, standard plans must be willing to accept any willing provider, and tailored plans can still have closed networks for behavioral health services. The managed care for Medicaid is very much like typical private healthcare where there's a network of providers. The other big change for managed care is that the appeal process you now must exhaust at the plan level. So you must do a plan level appeal before you get to a state fair hearing. And the big change for beneficiaries is they're going to now have to choose a health plan for most of our beneficiaries, and an enrollment broker will help them with that. And that means they may not be able to get all their providers in the same health plan that they currently have. An important thing to remember about Medicaid transformation is there's some things that are not changing under the whole system change. A big thing is that the eligibility rules and the eligibility process for Medicaid are not changing. Neither are the covered services. Some new services will be added. So, for instance, some of the social determinants of health services will be added over time. How services are authorized and delivered for exempt populations will not change either. The waiver wait lists will not change, for such as innovations waiver or CAP-C or CAP-DA waivers will not change, and CHIP eligibility will not change, although the CHIP beneficiaries will enroll unless they are exempt. So what does this new structure look like for us? The legislation required DHS to contract with 4 statewide prepaid health plans. You'll hear us use the terms prepaid health plans, PHPs, or use the word plans or standard plans, sort of all the similar things. The legislature required up to 12 regional plans to cover up to 6 regions, and those plans could either be commercial plans, such as commercial HMOs, or provider-led entities, which would be controlled by North Carolina providers. And also, the LME MCOs would continue to serve and exist as a PHP for tailored plans for specific populations. So under the new transformation system, we will have 2 types of health plans. There will be standard plans, which will include most Medicaid enrollees, including those with mild to moderate behavioral health problems. And then we will have tailored plans for people with serious mental health or substance use disorder needs, intellectual and developmental disabilities, or traumatic brain injury. These tailored plans will have a delayed launch until at least July 2021, but LME's MCOs will exist in the meantime. So as we said, standard plans exist across regions. There are 6 regions, as you can see by the map here. The statewide plans that are going to exist when managed care starts North Carolina are Blue Cross Blue Shield, AmeriHealth Caritas, United Healthcare, and WellCare. In regions 3 and 5, there will be a provider-led entity called Carolina Complete Health, which is a partnership of North Carolina Medical Society and North Carolina Community Healthcare Association, along with Centene. We did want to note that appeals have been filed by 3 unsuccessful bidders in the RFP process to be a plan in North Carolina managed care. Requests to the judge to delay implementation are pending. So some of the timelines we're going to talk about today, if those appeals are successful, could get pushed out. So what happens to our LME MCOs? We already discussed this very briefly, but they will continue until July 2021 to manage care for MHDD SAS, but only for those with serious conditions. And we'll talk about more in the next slide. Physical health care for this population will be continued to go through fee-for-service. So they will not enter into the commercial plans unless some people could want to. We'll explain that more later as well. And beginning in July 2021, those LMEs will become tailored plans and manage both MHDD SAS services for those individuals as well as their physical health care. Yet again, the 2 people in the tailored plans will only be those with severe behavioral health conditions. The one thing to note is that there's still only be 1 tailored plan per region, so that the current system where LME MCOs operate in a region and you cannot have other choices will continue at least until 2025. So eligibility for tailored plans, we talked about those only being for limited people. It's set up to include or be based on diagnosis, which would include individuals with serious emotional disturbance or diagnosis of severe substance use disorder or TBI, or developmental disabilities as defined in the statute, or serious mental health conditions as defined by the 2012 settlement agreement with DOJ, including those in the Community Living Initiative settlement. And the other way people can be part of a tailored plan or identified as being in a tailored plan would be use of services. So this includes individuals who with 2 or more psychiatric hospitalizations or readmissions within prior 18 months, or with 2 or more visits to the emergency department for psychiatric problems in those past 18 months, or those who have been voluntarily treated within the prior 18 months. So it's all very much based on the services you've gotten in the past and your conditions. So enrollment is sort of the next big thing that's going to be happening for individuals moving into managed care. The transition timeline, DHHS came out with a graphic that I think is pretty helpful to understand how this works in the past month or so. And as you can see, the enrollment packets are supposed to start getting mailed at the end of this month. an open enrollment, which is when people can pick a plan with the help of the enrollment broker, which is Maximus in the state. People can pick the plan through most of the summer. And then if they do not pick a plan, they will be enrolled, and their healthy plan, their effective date will be November 1st. And then in the other regions, so that's being phase 1 and phase 2, in the second set of regions, that enrollment will start in September, with open enrollment going through most of the end of the year, except for until 12/13/2019, with a health plan effective date of February 1st, 2020. And as I said, it's separated by regions, which you can see in the map to the right as well. So as I said, under enrollment, individuals will be given a choice of plans. And there is an enrollment broker, which is run by Maximus in North Carolina, to help Medicaid recipients select their plan. And this should help them understand which plans have which providers in their network and other sort of important choices to individuals. The individuals have 60 days to select a plan and a primary care physician, and those who do not select a plan will be auto-assigned by the enrollment broker based on specific criteria. They'll have individuals have 90 days to change their plan for any reason. This is called no cause disenrollment and re-enrollment, and those who are exempt can disenroll at any time because their enrollment is voluntary. And members can also disenroll for cause at additional time, but for cause disenrollment is limited to a specific set of reasons for which they can disenroll. And then if they are denied that disenrollment, they will have the ability to appeal that decision. There will also be choice of providers within the plan. So each member will have a choice of their advanced medical home or other primary care physician. And if they do not choose a medical home, they will be auto-assigned by the plan to their advanced medical home or PCP. And if a member can change their AMH or PCP without cause twice per year, and more often if for cause, but they must contact the plan to change their primary care physician. So we've been talking a little bit about who must enroll and who's exempt, and there's delays, and I admit this is quite confusing. However, hopefully this chart will help. So those who are in, it's going to be almost all of the Medicaid participants unless they fit into an excluded category. There are two groups of people who can enroll in managed care if they choose to, but they do not have to. They could stay in fee-for-service if they want to. So those who can go into managed care or not include the Eastern Band of Cherokee Indians and those beneficiaries with serious intellectual or developmental disabilities or mental health diagnoses. So those people who are kind of currently served by the LME MCOs and meet the criteria for tailored plans. So who's out and excluded? There's a list here on this slide. I wanted to highlight quickly CAP-C, CAP-DA, people who have family planning Medicaid, nursing facility residents, and children in foster care. So children in foster care are delayed. They are expected to go into managed care later. So enrollment sounds a little bit confusing. There's a bunch of dates going on. There are a bunch of populations going in and out, and some people are optionally enrolled in managed care. They can go in if they want to. So that's going to create a bit of confusion. So the state is relying on data matches to determine who must enroll. Unfortunately, the state doesn't have data on those new to Medicaid or new to North Carolina. So the enrollment broker will have a higher duty there to make sure that those people understand what's going on, but that might not work out quite as expected. And that's something that advocates are concerned about. The state also has limited data on other groups, such as those aged 0 to 3, in terms of what kind of services they use and who is their primary care physician. And also the state's data may be out of date or incorrect. The state will also rely on beneficiaries not ID'd by the data match to raise their hand to self-identify as exempt from enrollment. So, for example, if a person uses some degree of mental health services, but it's not clear where they belong, whether or not they're exempt and might go to tailored plans, or if they're regular and commercial plans, they're going to be in that raise your hand group to say, like, I should be exempt and I don't want to be in managed care yet. They will be able to request, if they're identified as having to be in managed care, they will be able to request in writing that they disenrolled and be able to appeal that. the states will also rely on the providers to help request exemptions. So there's a bit of people who might be sort of lost in the middle. Even for those the state identifies as exempt, the state might send confusing letters that encourage enrollment in managed care standard plans. So be on the lookout for that. And for those who with mental health and developmental disabilities and substance use disorder who are enrolled in standard plans, they may not be able to get all of the services they need until after they successfully disenroll. Until they can go back to the LME MCOs for those services. So what do affected beneficiaries need to do now? Make sure that the DSS has their current mailing address, phone number, and email address, so they receive all notices about any changes with managed care and changes specific to them. And also make sure that in late June 2019 or later, depending upon which region they live in, they will need to start looking for a letter telling them to enroll in a health plan and to contact the enrollment broker to ask if they are exempt. And if not exempt, they will have to ask the enrollment broker to help choose the plan or the doctor. And really quickly, kind of what to know here is that if you're talking to somebody, either a provider or a advocate who uses LME MCO services now or has in the immediate past or may need to in the future, they might be in that exempt population and they might be better served in an LME MCO or in a standard plan. It's going to really be dependent on what services they need. So really watch out for those people and make sure they understand what's going on and what their options are. And also if it's an other exempt population. So I'm going to turn it over now to Misha to talk about services changes and what is going to happen under transformation to services. Anyway, Misha.
Thank you, Elizabeth. Thanks, Elizabeth. And there is some spontaneous landscaping going on our end. So if you start to hear something roaring in the background, I'll just speak up a little bit louder. Just someone please let me know. Okay, so service changes. It's important to understand that North Carolina's move to Medicaid managed care is a change in how Medicaid is delivered. It's not a change in services. Under Medicaid managed care, prepaid health plans will be required to cover all the same services that they cover now under the fee-for-service model. So if a service is covered under Medicaid fee-for-service, it will also be covered under Medicaid managed care because, again, the overall structure the overall funding mechanism isn't changing. It's not the structure that's changing overall as far as delivery of services and who's eligible. It's just the funding mechanism. So we want you to note here that PHPs will now be responsible for non-emergency transportation. PHPs will be required to assist with arranging for non-emergency transportation for its members. However, DSS will remain responsible for transportation for populations that are not moving to Medicaid managed care. So any of the populations that Elizabeth referenced before that will be staying in fee-for-service, those populations will continue to have their transportation managed by DSS. So PHPs may not require referral or prior authorization for emergency services, family planning, direct access to a women's health specialist, children's screening services, or to first mental health or substance use assessments that are within the first 12 months. So again, that just echoes services are not changing, just the structure. We'd like you to note that certain services will remain carved out of Medicaid managed care, meaning they will not be moving to the new model. They will remain in fee-for-service. So dental services, eyeglasses, services that are provided by local education agencies, and services that are provided by children's developmental services agencies. Those services are all carved out. And finally, we want to note that PHPs must have a system to review drug utilization and drug interactions, incorrect doses, appropriate use of generics, and also screen for opioid misuse. So that will continue under Medicaid managed care. So now we will talk about the services that will be offered under the standard plan and the services that will be offered under tailored plans. So this slide is a great tool for beneficiaries to use in order to compare what services they can expect to see in standard plans versus what services they can expect to see under tailored plans. The services on the left are everything that you could expect a tailored plan to provide, a standard plan to provide, and then the services on the right are tailored plan services. Now, the tailored plans will provide all of the standard plan services in addition to what you see in the right-hand column. Standard plans will also cover some enhanced behavioral health services, such as mobile crisis management, substance use disorder intensive outpatient programs, psychosocial rehabilitation, and EPSDT and diagnostic assessments. And now we will move forward to talk about network adequacy. So PHPs are required to contract with essential providers, and an essential provider is defined by the enabling legislation for Medicaid transformation. They are federally qualified health centers, rural health clinics, rural health centers overseen by DHHS, free and charitable clinics, states' veterans homes, and local health departments. Those are all considered essential providers. So one of the roles of the PHP is to make sure that beneficiaries are receiving the types of services that meet their needs, no matter where they are as far as ability or culture or background. So PHPs must use resources to help providers provide services in a culturally competent manner, and they must ensure that network providers provide physical access, reasonable accommodations, and accessible equipment to people with disabilities. Another requirement for the PHPs is maintaining a provider directory. The provider directory has to be updated at least monthly. It must include the provider's names, the group affiliation, the location, the counties that they serve, their websites, which specialties that they have providers for, as well as whether they have any type of linguistic capabilities, and whether or not they have any type of cultural competency training, and of course a phone number where the beneficiaries can reach them. And then one final thing to note for providers who are applying to be within a PHP's catchment area, DHHS will establish a centralized credentialing process that will include a standard provider enrollment application and qualification verification process. And the goal with that is to make sure that providers aren't overburdened with paperwork trying to network with all of the PHPs that we have. So now we will move to discuss care management. DHHS estimates that 100% of enrollees will have access to care coordination, and about 22% of enrollees in the standard plan will have needs that require, 100% will have access to care coordination, and then about 22% of the enrollees of a standard plan will have higher needs that require care management. Care coordinators are expected to perform tasks such as conducting care needs screening, providing links to community resources, and also, given the higher member to staff ratio that these PHPs will have, we expect that care coordination will be an important role for the PHP to fulfill by not only discussing what the best way to provide services with stakeholders, but also, using a resource such as the statewide resource guide that I will reference in just the next slide, which is called North Carolina Care 360, but also making sure that when they refer beneficiaries to services, the care coordinators, that they're closing the loop and making sure referrals just don't go up and ended, and beneficiaries aren't just given a number and then sent on their way. So a designated care management entity is an entity with which the PHP contracts to provide care management or care coordination services. And the entities that could be included as a care management entity include advanced medical homes, local health departments, and other contracted entities. And then the priority populations that DHHS expects to see for care management include individuals who require long-term support and services, adults and children with special health care needs, individuals who are identified by the PHP as being high risk, individuals with unmet needs. So those will be people who are homeless, who experience domestic violence, who fear for their safety, or who have other unmet needs, which I will mention when we discuss the Healthy Opportunity pilots. And also, care management is expected to be provided for high-risk pregnancy populations and also at-risk children from age 0 to 5. So if an advanced medical home or a other entity doesn't meet the care management responsibilities, or if they fail to meet the quality standards, a PHP can seek permission from the department to terminate the contract with that entity, and then they're no longer required to pay the care management fee. And so that's just one of the many checks and balances, which I'll touch on in a bit, that DHHS has included as we move to Medicaid managed care to make sure that quality services are provided and that there's oversight. So now we'll discuss Healthy Opportunities pilots. The goal of Healthy Opportunities pilots is to address the non-medical factors that drive health outcomes and costs, such as unstable housing, insufficient food, lack of transportation, and interpersonal violence. If an unmet need is identified, the PHP is expected to connect the beneficiary to community resources, and if it's a high needs case, to provide more support as needed. So I mentioned North Carolina Care 360. North Carolina Care 360 is a effort that launched in January of this year. It is a statewide tool to connect individuals in need with their community resources. So typically what we see now is that resources in the community are very fragmented, and populations and people in need can't get care across the state as they should. So a tool that we will have is North Carolina Care 360. And this is really part of the department's no wrong door approach. So implementation for North Carolina Care 360 started in January of 2019, and the department expects North Carolina Care 360 to be available in every county in North Carolina by the end of 2020. So in addition to statewide efforts in select regions, North Carolina, in select regions of North Carolina, PHPs will work with community-based health and human service organizations to launch Healthy Opportunity pilots. So the regions will be a mix of urban and rural counties, and we expect the pilots to launch in early 2021. So that, again, the Healthy Opportunities pilots are meant to address the unmet non-medical needs that beneficiaries may face that are often barriers to healthcare. And the target populations include children and adults with chronic conditions, who are homeless or at risk of homelessness, who are food insecure, who may have issues with toxic stress. It includes women with complex social needs, pregnant women with complex social needs, and adults who have repeated avoidable use of emergency departments and hospitalizations. So in the next 3 slides, so now we're going to move forward to provider payments. The next 3 slides have to do with provider payments, but in the interest of time, I'm going to allow you all to review that section on your own. At the end of this presentation, as Brendan mentioned, there is a link to the department's very in-depth provider webinars. Okay, so monitoring oversight. Like I said, there are a number of systems in place to ensure that PHPs properly provide quality service to North Carolina's Medicaid beneficiaries. On the front end, PHPs must engage with different stakeholders, such as community and county organizations, the enrollment broker, the local DSS, and the ombudsman programs when they're addressing certain issues All of that input makes sure that issues that the PHP may not see from their perspective, if another stakeholder in the system sees it, that information will be shared and a solution can be found. Additionally, PHPs must have compliance plans, methods to prevent, detect, and report fraud, and they also must have procedures to recover costs from third parties when there's third-party liability. So now I will go ahead and turn the presentation over to Doug, and he will walk you through it.
Thank you, Misha. We're now going to talk at some length about beneficiary protections that are built into the plan and some of the issues that we expect to see for beneficiaries and their need for advocacy. I want to start by mentioning that we just mentioned previously that there will be a beneficiary ombudsman. In fact, the RFP for that just came out, which we're very pleased about. However, there's going to be a delay before that ombudsman can get off the ground, probably sometime in November, it looks like. And if a stay is not granted by the judge in these appeals we mentioned earlier, then again, a lot of people will have already gone through the period of having to enroll in managed care without there being an ombudsman. And the enrollment broker will be available to those folks at that time, but if there are problems during that initial rollout, it's really going to be up to other advocates, especially before that ombudsman is in place. So let's jump into these the specifics here. We expect there to be a lot of confusion. I'll bet there's confusion from people on this call because it's a very complex process, and there's going to be a lot of transitions between people who go into fee-for-service, people who go out of fee-for-service. Just one example, people who have Medicare are exempt from managed care. Well, if you get Medicare, if you become Medicare eligible while you are enrolled in managed care, you should be immediately transitioned out of managed care. But will that happen? Another example is people who are new to the state or new to Medicaid. They actually are exempt. They may be exempt from managed care, but the state has no data on them, and they're going to rely, as we mentioned earlier, on this raise your hand process, which turns out is like a 15-page form that this person is supposed to complete with all kinds of documentation attached to it to prove that they are exempt from managed care, that they need these enhanced mental health services. And this is a population that, of course, is very ill-equipped to raise their hands because they're in a mental health crisis. And meanwhile, they may not be able to get the services that they need. There's also where we fear, there's issues, the department is concerned about not having correct addresses for everybody, that DSSs have not been updating everybody's addresses because they just don't touch the file often enough. So people may not even get their enrollment packet. They may end up auto-assigned into managed care and then into a plan and to a provider that they don't know about till they show up, and all of a sudden they do not have, they're told, I'm not your doctor anymore. Then, will they get the assistance they need? We hope so from the enrollment broker, but if they don't know about the enrollment broker, or if they can't get through on the phone or whatever, or if the enrollment broker doesn't have good data. For example, the enrollment broker is supposed to have provider directories from all the plans saying who their providers are, but will those provider directories be there in time? Will they be up to date? We know that a lot of providers still aren't enrolled in all these plans, and they're going to be constantly changing. Or will it say if the provider's not taking new patients or new Medicaid patients? Probably not. So they may think that their provider is in network, but in practice it may not happen. Also, the issue of inadequate provider networks is a big concern because we already see that with the LME MCOs. If we're now going to see that with other Medicaid services as well, where a lot of providers simply aren't enrolled with that plan because they don't like the rate that's being paid, or they don't want to contract with all these different plans. then we worry about people having timely access to care. On paper, the time and the distance standards, the appointment wait times in the network adequacy rules in the contract are excellent, but will the plans really meet those? And if not, will that be enforced by the state? Those are concerns that we have. Obviously, we're concerned about inadequate and improper denials of services, and in some cases that services may get denied without written notice. We're very concerned about the confusion about Medicaid transportation. People are used to getting it from DSS. All of a sudden they have to get it from the plan. Will the plans have the transportation networks set up, and will they be adequate? Do the plans understand EPSDT? There's so many things that we don't know yet about these plans, and many of them come from out of state and do not all have great track records in other states, to be perfectly honest. So there are real reasons to be concerned as people shift into this new system. Remember, we've never had managed care except for the LME's MCO in North Carolina. So this is a completely new phenomenon for these almost 2 million Medicaid recipients who have to learn about this new complex system and then make successful transitions from one system to the other, and then maybe back to the first one as their situation changes. Next slide. So we obviously, for now, the most important things beneficiaries need to know is choose the health plan and doctor unless you are exempt, because otherwise you'll be auto-assigned. But there are luckily liberal rules on changing your plans, changing your doctor. So if you're not satisfied, ask to change. The eligibility is not going to change. Medicaid should continue to cover the same services. And I say should, because again, we have to see whether that happens in reality. We know on paper that's supposed to happen, and we know that the clinical coverage policies that the state has, the plans are supposed to follow those. They're not supposed to make up their own rules about who gets services, but will they actually do that? And then, of course, you have to see in-network providers, but there are exceptions to that rule. If they can't provide an in-network provider in the timely manner that's a reasonable distance from your house and that is the specialty provider that you need, then they have to cover an out-of-network provider that you request. But will that happen? And will they tell you that? And will they assist in finding that provider? Those are the questions that we have concerns about. And again, if you need enhanced services, you could be in the middle of a mental health crisis. And if you're in a standard plan, all of a sudden you need services that you can't get until you successfully disenroll. And will they get help in doing that, the help they need in doing that? Next slide. So there are important rights that beneficiaries have. They have the right to free advice from the enrollment broker. They have the right to switch plans. As we said, 90 days for any reason, good cause, the rest of the year. They can request to disenroll from a plan or to disenroll from managed care, and they can appeal if that request is denied. And that appeal process, by the way, there is no internal plan appeal step of that appeal. It goes straight to the Office of Administrative Hearings, just like fee-for-service appeals do now. Again, I mentioned the right to out-of-network care, the right to have your care not interrupted if you transition, and of course, the right to appeal if the plan denies, reduces, or partially approves or stops coverage for needed care. So there's two things that people get confused about: an appeal versus a grievance. An appeal is generally to appeal a benefit determination, that is a denial, reduction, or partial approval, or a termination of services, a request for services generally. And that that you have 60 days to ask for that appeal. You can ask for it orally, but you have to follow up in writing. There are good cause exceptions. Then you have to exhaust this internal appeal process. They are supposed to bring in someone different to hear that. You can ask for an expedited appeal. And then, of course, if you fail in the internal appeal process, you go on, you can then ask for a state appeal within 120 days before the Office of Administrative Hearings, just like you can now. What? Next slide. So and notice those time frames have increased. For fee for service, it's a shorter time. You only have 30 days to ask for that OAH appeal. So a grievance is different. A grievance is you're complaining about something else, like I don't have actual access, you know, I can't reach my care manager. I'm not getting the language access I need or the disability accommodation I need. My provider is not showing up, etc. Just a whole range of any other problems. You can file a grievance with the plan about that. Of course, there are no real appeal rights if they deny your grievance or don't take any, you know, don't give you any relief from your grievance. And that's where I think the ombudsman is going to be so important, because that's really the ombudsman's job, is going to be to help people resolve problems without having to go through an appeal process. But we'll see, you know, how soon they can get that going. Next slide. Obviously, this is the technical definition of that adverse benefit determination that is appealable. But as I mentioned, the main thing is if you are denying, reducing, or partially approving services, or if you approve the request, but for a shorter period of time than what was requested, that is also appealable. And of course, if they don't act on your appeal in a timely manner, then you can go straight to OAH. So that's why that's in there as well. And if they don't provide services in a timely manner, that is also an appealable action. So now continued benefits, they have to continue benefits if you timely appeal, but only if it involves a termination before the end of the authorization period. So if you're authorized for the service for 6 months, and at the end of the 6 months, you request reauthorization, I need it for longer, I need it to keep my service for longer than 6 months, and they deny it, that under managed care regulations is not considered a termination, it's considered a denial. So there's no right to continued services pending appeal. It's only if they reduce or stop your services during the authorization period. Next slide. So there are other protections. The marketing materials have to be approved by the state. They can't do direct solicitations door to door by telephone. Please join our plan. We have the best plan. Again, they have to provide all these services for people with disabilities and limited English proficiency. They have to operate a member services line, health service, behavioral health line, a nurse line. They, of course, have to follow the state appeal procedures, grievance procedures, timeliness standards. And in fact, the state is going to be telling them what forms to use, what the notices look like, what the enclosures that go with those notices look like, how they're pre-populated. All of that information will be dictated by the state. I know that because we've been working with them to do just that. And they also will be establishing a member advisory committee and long-term services committee, and they are supposed to facilitate transfers when appropriate. And that is going to be a critical element, I believe. So here are some issues to watch for. I've already alluded to some of these, but let's just run through this list. And I encourage you to keep this list as a checklist when you're talking to clients about their experience with managed care and to help us know what's going on out there. So enrollment issues, are they exempt from having to enroll? Are they required to enroll anyway? Were they told that they could disenroll? If they do request to disenroll, was that decision made in writing and with appeal rights? Were they given misleading or aggressive marketing practices subject to that? Is the provider directory accurate? Are the providers listed really accepting new patients? Next slide. So were they given a choice of plans before being auto-enrolled? Was the enrollment broker actually accessible and helpful in choosing a plan? And how about in requesting an exemption or explaining to people who has to enroll and who doesn't have to enroll, or to help them change plans? Were they permitted to change the plans within 90 days? Do they have good cause after that? And did the plan explain that process and how to do that? Was a request to change plans acted on with a decision in writing and appeal rights if that is denied? So if their mental health condition worsened so that they now need enhanced mental health services, were they smoothly transitioned from a standard plans to the LME, or after 2021, the tailored plan, without interruption in care or a delay in getting those services? B3 services, for example, a lot of clients need those, or state-funded services. The only way they'll be able to get those is through the LME or through the tailored plan. If they started getting Medicare, I mentioned that, or they got into the CAP DA or CAP C program, were they promptly disenrolled from managed care? They have to be, but is it going to work? Is it going to happen quickly? Or is it going to work the other way, where plans actually try to disenroll or encourage people to leave their plan if they're costing them too much money, or if they are just making too many complaints or grievances? Because that is another, obviously they have a financial reason to do that, and so we have to monitor that closely, that kind of inappropriate behavior doesn't go on. If they leave managed care, do the previously approved services continue without interruption? Or if they just change plans, but the provider is not in the new network, the state has said that they are working to make sure that happens. We are still waiting on some of the details as to how that has happened, but the state is promising they'll be able to continue with that same doctor provider for at least 90 days. Let's make sure that happens. So access to the assistance they need. Does the handbook and the beneficiary materials accurately describe their benefits, their rights and procedures, their appeal process? The state is providing a model handbook that the plans will be required to mail out to all of their enrollees. We've given input on that, but we haven't seen the final version yet. And of course, whether the plans change it in some way, we'll have to watch that. How to contact the ombudsman, that's going to be critical that be included with materials, and it's going to be very challenging initially during this initial rollout because we don't know who the ombudsman's going to be. So in the absence of that, are the materials going to say, well, here's how to contact legal aid or disability rights or one of these other people who could possibly help you? So do the plan and providers meet the 1557 requirements? Do they provide services in a culturally competent way? And again, the 1557 requirements are very strong on paper, and this applies to the providers as well as the plans. Translators for materials in the person's preferred language, taglines in 10 different languages, all their written materials in the person's preferred language, etc. But this is very challenging for providers and for plans, and so whether the people with those needs really have them met is something to pay close attention to. Next slide. So were they allowed to change primary care physicians when they needed to, at least once a year and more often if they have a good reason? Do they need an advanced medical home rather than just a regular personal primary care physician? Is that PCP providing quality care management for care coordination at least? And remember, it's supposed to be local care coordination, not at the plan level, not by somebody on a toll-free number. It's supposed to be face-to-face by somebody who they meet with at their doctor's office or somewhere else like that. And is that really going to happen? And it's a wonderful concept, but we need to make sure that the plans really do it. And given the rushed, the hurried startup here, we have some concerns whether it really will. Will they have timely access? Like I said, within those time and distance standards and appointment time standards to get the treatment they need, including specialty care, in-home care, all the rest of it. Did they tell them that they could request out-of-network care? Were they denied that when they had a good reason? Were they given the information about transportation to medical appointments and that it's free? And were they given a denial with appeal rights in writing if that transportation is denied? Next slide. So does it cover everything under plus EPSDT services? And do they follow the state's clinical rules and follow EPSDT rules? Do they meet mental health parity requirements in their coverage policies? They're supposed to review that and provide a plan for that. Do they follow the state's definition of medical necessity? And do they meet all the EPSDT requirements? Outreach, informing, screening, covering if it's necessary to correct or ameliorate that child's condition, even if it's not covered under the state plan, and are actually arranging for those services to happen rather than just saying, you go find your own provider. Those are the requirements of EPSDT, but will the plans do it? Does the plan actually discourage people from requesting services or give misinformation? Do they say, well, you can request that service, but it'll get denied? Or no, we don't really cover that for people in your situation. Well, if they discourage a person from actually requesting the service, then the due process never gets triggered. They never get their notice of denial with the right to appeal. So this is sort of the first step of due process, is making sure that they don't discourage people from asking for the services in the first place. And then that they make a decision on that promptly, that they issue it in writing, that and this last bullet point we're very concerned about, that if they're covering long-term services, do they set the authorization period for such a short time that you have to keep asking over and over again, even though you have a chronic condition? Because there's language in the federal Medicaid regulations now that prohibit that. Next slide. So does the plan provide written notice whenever care is denied? We've talked about that. Is it on the state's approved form with the right enclosures? Are they pre-populated the way they're supposed to be? Did they specify on the notice a real detailed reason and the real specific legal authority? Does it make clear how much is approved, how much is denied? Do they include the right to continued services if that applies? And this last one is very important. Is the envelope postmarked the same day as the date on the notice? Because it is required to be. They have to actually make sure it goes into the hands of the post office on the date the notice is dated, because again, the clock is running for the client, and that's why they've got to get it into the mail that day. Next one. So was it approved in a timely manner? If it was requested, was it processed timely? This is the appeal. Was it timely processed? Was the expedited appeal granted? And by the way, if the provider writes on the form that an expedited appeal is necessary because the person's health or may be in danger or well-being may be in danger without expediting the appeal. The plan has to accept that. They can't refuse it in that situation. Will that actually happen? Will they offer assistance to people who need it in how to file the appeal or fill out the forms or during the process? Will they give them, will they discourage them from asking for the appeals or encourage them to drop it? Will they allow it to be filed over the phone? Will they give you the entire file, their entire file, not just what they want to give you to review? Will they allow you to present your case in person? And will they make sure someone with appropriate credentials who's independent decides that internal level of appeal? Then you have the OAH appeal, which is the next slide. So the issue here, again, you have 120 days. They have a certain amount of time to make it. They have to give you the correct information on how to ask for that appeal, which has to be in writing to OAH. And then again, they have to make the file available, and OAH is now required to expedite the appeal if that is warranted. And will they again reinstate or continue services if that applies? So that ends my part of this, and I'm turning it over to Brendan.
Thanks so much, Doug. Appreciate that overview. I know we're covering a lot of content, but I thought that was a really great overview. Just really briefly, I'm going to cover a few quick things. Obviously, you all as healthcare providers, as service providers, as advocates, you all play really important roles across many different touch points that Medicaid beneficiaries are going to have with the system as it's changing. So there's a lot that you can do, but in particular, obviously spreading the word of that Medicaid transformation is coming, helping your patients, your clients, beneficiaries understand their options, understand their obligations, whether they're in the phase 1 or phase 2 of the Medicaid transformation rollout, what their obligations are right now, some of the things that we covered earlier that Elizabeth and Doug both covered in terms of the beneficiary should make sure their address is up to date with their Department of Social Services, and then of course be ready to look for information in the mail from North Carolina Medicaid and eventually from their prepaid health plan if they are going to enroll or auto-assign if they're not exempt. And of course, so much of the Medicaid transformation is about trying to, at least ostensibly, to improve population health and to really make sure that we're aligning payment systems and delivery systems with our population health goals. And it's so difficult to be having those conversations when we know that there are hundreds of thousands of people who are uninsured and not in the system who are stuck in a coverage gap. So while that's not the focus of today's webinar, we do hope that you are also out there asking your state lawmakers to close the coverage gap. Our legislative session is still going on, and we still think there's a chance we can make this happen this year. All right, so if folks have questions or concerns, particularly beneficiaries, they should contact one of the following organizations for free legal advice and assistance. I want to remind you all about those handouts at the right-hand side of your screen on the webinar pane, the GoToWebinar pane. That third one, the NC Medicaid Transformation one-pager, I'm going to pull it up right here so you all can see it. This, well, it looks like it's loading awful slow. Here we go. This is a one-pager that our organizations with NC Child, Legal Aid, and Physical Legal Services have put together to provide just 2 pages of information about what we think the public and beneficiaries need to know, as well as who to call if they need free legal assistance. So we definitely recommend you download that and save it, and feel free to share that with the public and others, because we think it's really critical that we arm people with information that's not only useful, but that's also actionable if they need to take some sort of action. As we alluded to earlier, there's a lot of other information. We know a lot of you on this webinar are healthcare providers, and we're so glad that you joined us today. There are other places you can get more information. Obviously, you might not be able to click this link on the webinar right now, but you can download the slide deck in the handouts section, and you can access this link for the provider trainings. There's also a lot of policy detail in these other links where you can find out more information. And from there, we're going to go ahead and jump into questions. And I know a number of you are sending questions in on the line. Just to remind you, you can still type in your questions and send them to us. So you can just enter in, click open that questions tab on the GoToWebinar pane, type in your questions, and we'll review them and start answering your questions. So I'm going to go ahead and unmute the lines of my fellow panelists, Doug, Elizabeth, and Misha. And I know we also have Lee from NHelp on the line here who can help us tag team some of these questions. So we appreciate you being here too, Lee. So I'm going to go ahead and get us started and just ask a few questions that we've gotten in already. First, I want to start with one. We're getting a lot of questions about patients living with intellectual and developmental disabilities and how things will work during the transition period. So let's start with this one here. And Misha, I'm going to turn this to you. So this question that we got says, how will someone not currently using IDD services change over to a tailored plan when they want to start receiving services?
So if someone needs to use a tailored plan service when they're not currently on the tailored plan, when their provider tries to submit authorization for that service is when they'll be moved over to the tailored plan service. And I believe it's 48 hours that it'll take between the PHP and then the LVMCO that's running the tailored plan to make the change. So you won't be prevented from making the switch to a tailored plan, but it'll take about 48 hours for the service to start.
Thank you, Misha. All right, another question that we got. Looking at this, here we go. So this one might be for you, Doug. Someone asked, how will families be able to see multiple providers across the state and, this one's important, even out of state? Could you discuss some of those processes, Doug, and maybe some barriers that people might face?
Oh, it will not be easy. Of course, the general rule is you have to stay in network. And of course, people who work with the LMEs, MCOs are used to this. In fact, those networks are really closed. At least the standard plans are going to be required to contract with any willing provider. So if your provider is willing to contract with the plan, then you have a solution there in terms of assuming they can agree on the rate, is just have them contract with the plan. If you do need an out-of-network provider, you're going to have to show that there is not an in-network provider who is appropriate and who is actually available to provide that service to you. And then you're going to have to make a specific request for that coverage of that out-of-network provider. And then, of course, it may get denied. They may say, oh no, our in-network services are just fine. And then you're going to have an appeal on your hands.
Thank you, Doug. All right, we have a number of questions coming in. So you all, those of you on the line, still feel free to keep sending in your questions. We'll keep asking them. We'll keep answering them. We've still got plenty of time to answer your questions. Another one here that I guess I'll ask also again to you, Doug. I think this is with respect to phase 1 and phase 2 regions. This person asked, will the enrollment date, or perhaps the launch date, is that based on the residency county of the beneficiary or the county in which the Medicaid application or approval was done?
Those should, in the majority of cases, be the same. But you're right, there are some cases where people are receiving services out of their county. Now, a lot of those folks are exempt from managed care anyway. So I'm sorry, maybe somebody else knows, which I haven't seen them make that distinction between the two. In terms of if you're not living in the county that actually is the one covering your Medicaid. I would assume they're going to start with the county where you get your Medicaid, and you're going to probably have to request if you want to change regions for some reason.
I don't have anything to add, so I'll move and take another question at this point. I'll maybe have Elizabeth take this one. Elizabeth, could you tell us any more about the ombudsman? The specific question was, will there be just one ombudsman? Could you talk a little more about the program and what we expect it to do?
Sure. the RFP is issued just for one, and it was designed this way as well, for one statewide ombudsman program. There is the expectation that there will be some level of local contact to some degree for the ombudsman program, but there will be just one statewide ombudsman program that would operate sort of a centralized system to help beneficiaries. But they're in the RFP, and I haven't read the new RFP fully through, but there is still this expectation that there's some degree of local, at least outreach and other kind of more localized opportunities for contact with them.
Thanks, Elizabeth. Another question that I have, and maybe I'll put this to you, Misha. It's a question that we got early on, which is how available will the enrollment broker be to members? And in particular, this person means how available will they be in person, not just by phone or online?
That's a great question, Brendan, and maybe someone else, if I'm incorrect, can Doug or Elizabeth correct me, but there will be a 24-hour enrollment broker line that beneficiaries can use to report issues and problems they're having. As far as in person, my understanding is that there will be, in some counties, an enrollment broker in the actual DSS office, but that's not going to be the case for every county. So if the enrollment broker doesn't have a presence in that DSS county, I'm not quite sure what the alternative would be as far as in-person connections.
Thanks, Misha. Doug, do you have anything to add to that?
Yeah, I think it's mostly going to be that call center. They are supposed to do some outreach in different communities, but as far as I know, they still haven't started doing that. They're supposed to work with DSSs, get information from DSSs, but I'm not sure at this point whether that actual presence at DSSs is actually going to happen, at least initially.
Thanks, guys. I appreciate those answers. We've got several other questions here. I might ask you this one, Doug. How long will it take for the change to take place when someone changes their advanced medical home? So this is assuming they've already been enrolled, so they've already been auto-assigned to an AMH after being auto-assigned to their PHP. How long will it take for them to change place, or how long will it take for the change if they want to switch to a different advanced medical home or primary care provider?
I cannot remember the rule. I know there is one. I think that in the case of an emergency and a more urgent medical condition, it's a matter of 24 to 48 hours and maybe 7 days otherwise, but that's just from memory, so somebody tell me if I'm wrong.
Elizabeth, Misha, do you guys remember or have anything you want to add?
I don't remember the exact timing either, but it is pretty quick, especially if there's exigent circumstances.
Thank you, guys.
Yes, I agree.
Great. Another question, we've gotten a few questions about medications and prescription drugs. I know we mentioned something briefly about this, but could someone answer this question? And maybe I'll put it to you, Elizabeth. On the medication side, will each plan have its own formulary, or will there be a universal formulary for all the plans?
So somebody may need to jump in if I say this incorrectly, but I believe it starts off with a universal formulary, and then at some point the state is planning to allow the plans to use their own formularies, but I could be mistaken by that.
No, that's exactly right. They can propose after year one, they can propose their own formulary. It's formulary. It has to be approved by the state.
Thank you, Doug.
Thanks, Doug. Thanks, Elizabeth. We're getting a few other questions that I can answer real quickly. Someone asked if these questions and answers will be saved for later review. This part of the webinar is being recorded and transcribed, so we will make sure that that's available for everyone, so you can still review those. And we will dig through all the other questions we've received, and we'll see if we can make an effort to get back to you all on those. I also got a comment from April over at the Community Health Center Association indicating that The enrollment broker is currently trying to schedule enrollment events, but we don't know how many or where. So it sounds like there might be some activity starting there on that front by Maximus, the enrollment broker, to do some outreach and education. Another comment that we got, which is a little bit of a comment and a question that I thought would be helpful for us to clarify, was regarding the ombudsman program and someone who had experience with the long-term care ombudsman. And I think some of this is also to do with language, that the long-term care ombudsman, when we talk about that, you often mean one person, one individual. But I think with this ombudsman program for Medicaid managed care, we're looking at a much larger staff. Doug, do you know yet at this point, I haven't gotten through the entire RFP yet that they re-released. Do you have a sense of what size workforce they're looking at, or is that to be determined?
Well, they didn't specify that, but they certainly specified that you have to accept a lot of phone calls, do a lot of warm handoffs, resolve a lot of problems any way you can, track systemic trends in the problem and report that to the department. So I think that it's going to be it's going to take a significant number. It has to be a North Carolina nonprofit, by the way, who has experience doing Medicaid advocacy. And I think it could take a team of groups to do all this work, because it's a lot of people and there's going to be a lot of confusion.
And I can add something on that, Brendan and Doug, that in other states, the demand on the ombudsman program, they're called various different things in other states, whether it's a beneficiary support system or other, has been quite high, especially in the initial rollout period, or when some of the grandfathering type activities. So if a state has said a plan can't change something for a certain period of time, then after that time period ends, there's been pretty demand on the ombudsman program. So it is a separate entity from our current long-term care ombudsman program, to make that clear. It's a separate entity, and it's doing something different. It's doing much more helping beneficiaries understand the system and how to work within the system, and what kind of steps they need to take to make sure they're navigating that system correctly. So it is a different organization, a different entity, and does other things. And the demand will be probably pretty high initially, at least.
Thank you guys for following up on that. Another question we've got in here is about provider networks. So do we know at this point, and maybe I'll ask this of Doug, do we know if provider networks are going to be available online so that helpers other than the enrollment broker, not just Maximus, can help beneficiaries figure out which one is the best plan to choose?
Yes, they are supposed to be. They're supposed to be at Maximus's website. However, Maximus's website doesn't even go live until late June, I think is what I heard. And the same time as when their toll-free number, I think, goes up. And then it's a matter of whether the provider directories have been submitted to Maximus by the plans and whether they're up to date. And so I think that even if you look one day and you see this is the provider network, I think at least during this initial rollout, there's going to be a lot of changes in that. And for that reason, I don't know, it might be a strategy to wait till it's closer to the deadline to choose the plan if you're concerned and you think the provider network might change during that time.
Thank you, Doug. All right, we're getting a lot of really good questions in here. Let's see, we've got a few that came in earlier. I want to make sure I'm not missing anyone. So we had a few questions about clinical coverage policies. I might send this one to Elizabeth, and others can chime in if they have thoughts. So will there be one coverage policy, or will each provider, and I think they mean plan, have their own policies that are roughly identical? Basically, if there is a coverage issue, we're going to need to identify the plan and have access to their materials. So could you talk a little bit about that, Elizabeth?
Sure, although I might turn it back over to Misha since she did the covered services part. My understanding is that the state will issue the clinical coverage policies or keep the clinical coverage policies. at least for the initial phases, and plans to keep that as some degree of monitoring.
Thanks,
That's my understanding as well, Elizabeth.
Thanks, Misha. Thank you, Elizabeth. And another services question that I'll put to you, Misha. Someone said, when you say that CDSA are carved out, what does that mean? Also, how or will this have, what effect will this have on contracted providers that we use for services?
So CDSA, the services provided by CDSA, will remain in the current fee-for-service model instead of moving to the capitated payments that you see with Medicaid managed care. And I'm so sorry, will you repeat the last part of that question?
I think they were asking what kind of impact that'll have on the providers they work for, so the CDSAs.
I'm not sure I can speak to that because it's not as though the service is being eliminated. It shouldn't have any effect on it, but I'm not a provider, so I can't really be sure. Doug or Elizabeth, if you have some other insight, please.
Well, I think the part that might be confusing here is that even if you are enrolled in a standard plan, you will continue to get this service, anything that the CDSA is providing, say speech therapy, occupational therapy, they will be, whatever it is, they will be providing that outside of the managed care system, and their providers network, whoever they've contracted with, that shouldn't change.
Thanks, y'all. A few more questions. So here's a good general question, just trying to put things into practice when the rubber hits the road. What will happen to a beneficiary who shows up to a primary care provider that is not enrolled in their assigned PHP? Will they be denied service? Will they be provided service without out-of-pocket costs? Doug, do you want to take that one?
Well, the short answer is that they will probably be turned away, and because the provider is not allowed to bill for providing, now obviously if it's one of the services that, for example, women's health services where you don't need a referral from a PCP, then or it's an emergency, of course, then of course they will be treated and the plan has to pay. But as long as the provider is in network, again, they still have to be in network, but otherwise you will need, in most cases, a referral from that PCP before you go to somebody else.
Thanks for that. Misha, I'm going to ask you this one, and maybe you and Elizabeth tag team because it's a little enrollment related. But for patients in LME MCOs, do they also have to enroll to receive services from a PCP provider contracted with a PHP, or do they just remain in fee-for-service?
So until tailored plans go into effect, and the tailored plan is doing both physical health and behavioral health, in the next couple of years, the person will just continue to get their physical healthcare services through the fee-for-service system, and they would not enroll into the commercial plan.
Thanks, Elizabeth. All right, we still have a few more minutes. If folks want to, we'll take a few more questions. So we still have a bunch here. If you have any burning questions, feel free to still send those in. Someone asked a question, which is what type of Medicaid ID or ID number will be used for the carve-out services that remain in fee-for-service? Doug, do you want to take that one? Or actually, maybe that should be for you, Misha.
Doug can absolutely take that question.
Okay, well, that brings up an important point, that people who are in managed care will no longer get the regular Medicaid card. They will rather get a card from their plan that does, however, have their Medicaid ID number on it. but some people were afraid will be confused, and they will think, wait a minute, I don't have Medicaid anymore. I've got this private health insurance. I don't even have Medicaid, so I can ignore that letter from social services about redetermining my eligibility. So we're really concerned that it be clear to people that it's not like you're losing Medicaid. Your card's coming from somebody different now. But then, because that ID number will be on that card, that is the same ID number that will be used for those carve-out services.
Thank you, Doug. We got a few questions about supports for folks who may encounter various challenges while trying to enroll. So someone mentioned, thinking about challenges that are going to face rural residents who have limited phone minutes, lack of internet access, lack of transportation, how they're going to be able to access the enrollment broker, given some of those challenges, given how much it may be phone-based, if there won't be in-person assistance. Will they be able to use the phone at their local DSS? What other resources are there for these clients? Doug, I might ask you that one.
That's a good question, and I don't think we have an answer to that. I think that they are really relying on people to have phones and to have enough minutes on their phone, or to have access to the internet, and then they can click online and chat online with somebody at the enrollment broker. But we, obviously, I know that people will contact their DSSs because that's where they're used to going when they have questions about their Medicaid. Then it'll be up to the DSS to help them get to the right place. And I know that the state is in the process of training all the DSSs on this transformation and warning them that they may need additional staff to deal with the number of calls they're going to get. But I think that there will be a lot of busy signals at a lot of DSSs after these letters go out.
Thanks, Doug. One more question before we wrap up. Unfortunately, we're not going to be able to get to all the questions today because we're getting close to our time. We're going to try to follow up with you all, but we'll take one more question. And this is about residents in assisted living facilities. Do these changes impact Medicaid cover personal care services for residents in assisted living facilities? Misha, could you answer that one?
So because the services covered aren't changing, just the mechanism by which they're funded, the move from fee-for-service to Medicaid managed care, it does impact them in that they will be either on a standard plan or a tailored plan eventually, but it doesn't mean that their personal care services will stop at their assisted living facility.
If I can just add, a lot of folks in those ACHs do have Medicare. So at least for now, they are supposed to be out entirely, assuming that DSS has the fact that they have Medicare in NC FAST, which sometimes they don't. But assuming it's in there, then yes, they are out for now if they have Medicare. However, if they don't have Medicare, then the issue will come up, is their adult care home an in-network provider? There are exceptions for people who are getting, for now, people who are getting long-term services for more than 90 days are carved out. But Elizabeth, help me, is an adult care home within that exclusion?
I was actually trying to think that one through, because that also, for many people in an adult care home or similar facility, the question will also come up too about which region their Medicaid home is in. But I don't think it's specifically carved out, and I'm trying to think through the LTSS part. We might have to get back to people on that question and think that through a little bit more and check some information.
All right, well, thank you guys so much. Thanks. We're going to wrap things up. I want to thank all of our presenters. Thank you, Elizabeth. Thank you, Misha. Thank you, Doug. Thank you, Lee, for joining on the line, and Becca for your support. And thanks everyone who joined today's webinar. You asked a ton of really great questions. We're going to do what we can to get back to you as soon as possible. We will be sharing a recording of this webinar, as well as the slides, a transcription, and the handouts that we provided today in a follow-up email. And of course, when you log off, you will get a chance to fill out a quick evaluation survey. Please let us know what you thought of this webinar, and if there are future topics that you want to hear more about. If you'd like to hear more from us, to dig into other issues around Medicaid managed care. We know this is going to be a complicated transition, a major transformation, and it's going to take all of us working together to try to make it the best we can as possible. So thank you all for joining today, and we look forward to talking to you soon. Thanks so much. Have a great day.